Hi everyone, and thank you for being here today. My name is Alison and I'm the Patient and Public Involvement Lead within Mobilise-D. As Mara said, this is one of a number of webinars that we've run, but we felt it was really important to make sure that we were talking about the things, I suppose, that matter to some of the patient cohorts that we are working with within Mobilise-D. And on that, we have a patient and public advisory group who are really central to a lot of the decisions that we do in Mobilise-D. They advise us on the design of things like this and help us to interpret some of the results. So when we went to them, they said we would like to talk about mobility and how it is important to us, but also specifically highlighting that from a clinical perspective, so that when our healthcare researchers basically know how important this is to us. So on that then, what we've done today is we have a couple of pre-recorded videos of a number of members of our advisory group discussing some issues that are important to them. And then we have a number of panelists here, both from our clinical side within Mobilise, but also from our patient advisory group, who will discuss some of these videos then in more depth. So the webinar is going to run for an hour. And as Mara said, you have the option to ask questions yourself or get involved, and we would please encourage you to do that. So I'll quickly introduce each of our panelist members here today before we kind of kick off with the first video that we have. So starting with our patient advisors, firstly, we have Tova. Tova is based in Israel and is one of our advisors in the area of Parkinson's disease. She has studied history and education and taught Hebrew for a number of years in the US before moving back to Israel. Tova currently works in the Israeli Association for the Advancement of Children and Adults with Learning Disabilities and ADHD, and she is their Resource Development Director. Next up, we have Werner. Werner is from Germany, but he's currently based in Scotland and is also one of our Parkinson's advisors. He comes from a mathematics and a computer science background and is very active in the patient advisory space, working not only with Mobilise-D, but also with IdeaFast, and has presented his experiences at various conferences and for multiple interest and research groups, including the Dundee Research Interest Group. Next, then we have John. John is based in the US and has a background in retail management and marketing. John is a board member for multiple COPD groups within the US, including EFFORTS, which is an international support group for the COPD community, and the COPD Patient-Powered Research Network. In addition, John is a frequent speaker and panel member at numerous national conferences dealing with respiratory issues. Next, then, we have a number of clinicians here who are also joining us. So first up, we have Walter. Walter is a professor of neurogeriatrics in Germany. He leads a research group focusing on the assessment of Parkinson's disease using sensor technology both at home and in clinics. And he is involved in multiple international projects in this area. And within Mobilise-D, he is the lead clinician for our Parkinson's cohort. We then are joined by Nikki. Nikki is a consultant in gerontology and is also based in Germany. Within Mobilise-D, she is part of the clinical lead group dealing with the hip fracture cohort with a special interest in falls prevention, osteoporosis, and non-pharmacological interventions for the two. And then finally, not yet here, but will be joining us later, is Clemens. Clemens is a geriatrician based in Germany and is the lead of our clinical validation study within Mobilise-D. He is also one of the cohort leads for hip fracture as well, and his research focuses on mobility, activity, and falls prevention. So those are our panelists who will be joining us today and giving their advice, their experiences, and their opinions on each of our questions. So what we might do is start off with the first video where you'll hear directly from some of our patient advisors, and then we'll discuss some of the topics that come from that afterwards.
Why is walking important to you? Because you have COPD. And I say, because it keeps me mobile, it keeps me going.
Walking gives you some kind of freedom. It gives you some kind of independence. You don't have to rely on other people for assistance. You know, you can do things yourself. You can walk from point A to point B or do something without asking people for help.
To me, it's very important that I can actually walk. As I say, it's the only means of transport I have is my two legs. And if they pack up, that's it, I'm afraid.
emotional debilitating thing is that you have to rely on other people, or you have to get assistance by other people. You feel like you use your independence. You feel despaired, you know, you think that it may not be better. And some people, you know, it can depresses you as well.
Once I missed a connection at an airport on the way to a COPD conference because I just couldn't walk from point A to point B. And that's when I recognized that I needed help. And the next time I flew, I had wheelchair assistance. And the first time I sat in the wheelchair, I just started weeping. It was, to me, it was horrible. I have an elderly woman able to walk, pushing me down the concourse to get from one gate to another because I couldn't do it myself. Emotionally, very disturbing.
Not to be able to walk in a straight line. And the minute you start sidestepping, people automatically think you're drunk, which can be very embarrassing. I had to go to the hospital to visit my mother. So I had to get 2 buses. So I had to get from one bus to the other bus, and the other bus was a queue. And I also find it hard to stand still. And I moved a couple of steps, and the fella behind me says, "I think you've had one too many, sir." And after that says, "I haven't been drinking, I've got Parkinson's." It's happened a couple of times. I went to a shop and I wasn't too good with my feet or my legs. And the young guy behind the counter, he must a student, mid-20s or something. I could see the expression on his face. God, I've got a donkey and I don't know what to do. I don't have training for this. So I got what I had to get, went to the counter, and I said, "I'm not done. I've got Parkinson's." And it was as if the world was lifted off his shoulders. You see him going, "Oh, thank God for that." That was it. So it's frustrating in a way, because you automatically been found guilty before you've been tried.
So we've just heard from some of the members of our advisory group there about their experiences of walking and why it might be important to them. And obviously we've heard directly from some of you here today. Would it be fair to say that walking appears to be linked to people's identity or how they see themselves? And I might start with you, John, if you wouldn't mind giving your thoughts on that.
I don't mind at all. Walking especially, I can't speak to Parkinson's, I can speak to COPD. Walking is incredibly important because it keeps the muscles moving, and without trying, I'm not a clinician, but I can give somewhat of a little lecture as to how the physiology works with oxygen. The muscles use oxygen as their fuel. The mitochondria, the powerhouse of the cells, are what allows us to be mobile and work. With COPD, the oxygen delivery is often not as constant or as much as we want it to be. And the less you do, the less you're able to do. So walking is incredibly important to maintain your independence, your ability to do things. It's a slippery slope. If someone with COPD decides to sit on a couch, they're going to quickly become, in my case, an old man with a hose in his nose. Fortunately, since I'm active, I only use my oxygen as needed because it's so important. Mobility is so important because it actually helps build more mitochondria, especially in the lower legs. So at the risk of going on and pretending I even play a doctor on television, which I don't, it creates independence. It allows you to live your life and the quality of life. You see, physicians And researchers need to understand quality of life is also incredibly important. So we need to stay active and do what we can. And with that, I'll pass.
Thanks, John. So, you focused in there on the whole part of independence and quality of life, and we did hear that within the video itself. Werner, what do you think of it from your perspective? Do you agree with that? How does it feel for you in terms of your sense of self or identity?
For me again?
No, sorry, for Werner. Sorry.
Okay.
Oh, Werner, you're on mute there. Sorry. Can I unmute you?
Okay, I'm sorry for that. Well, I completely agree with this. Walking and mobility is a part of the identity that you have as a person. It's, well, some part of my life is sports. And I used to do sports, play tennis, do inline skating for marathons and stuff of this nature. And all of a sudden, with the increase of the illness, things disappear. They are not available anymore. It's a part of my personality that I'm losing about that. And I see it over the years, even more and more and more. I have to give up a part of my life. And the other thing that was mentioned, the identity and the capability to lead your own life without any help is something which put your mind to, well, which actually is a real psychological problem over time. When you're not able to go shopping or do things that you need to do in your daily life, it's actually very complicated to bear.
Yeah, thank you for that, Werner. Tova, what about you? You mentioned similar things to Werner there actually in the video, things like going to the shops or normal activities. How do you see that in terms of your sense of self, or what do you think of what the guys have said there?
I think that both Werner and John and Tom said it all. It's keeping some kind of sense of normalcy, feeling like a quote unquote a normal person and not a handicap. And I think that for our well-being, for our mental well-being, for our whole well-being, it's very important to feel normal and not to feel handicapped.
Yeah, thank you. And from a clinical perspective, then I suppose I might pass over to Nikki first. Listening to the videos, and I suppose from your experience with dealing people, does that whole sense of identity come out when you speak to patients?
Yes, but not in the first case often. Often in the clinical situation, patients focus on the medical problems by losing the walking and independency in life out of sight. You have really to focus on that in the contact with the patient, and often I have to ask about it. What difference came up after a fracture or after a hospital stay. And yes, walking is really important for the identity of people, because it keeps them going and staying in their social contacts with the family members. And yes, coming from A to B on yourself is really important for everybody. But in the clinical situation, often it gets lost.
Thank you.
We have to focus on that as clinicians, to ask people, but I think people shouldn't be afraid to talk about that as well.
Yeah, that's fair. Okay, thank you. And Walter, then from your perspective, have you found something similar that actually that importance of it could get lost within the clinical space? Sorry, Walter, you're on mute.
Thank you, Alice. That is indeed true. That is also what we experience on our neurogeriatric ward. So this is full of people that have a mobility problem. What we also experience is it's not only about walking, it's also about transfer. So if you cannot stand up, you cannot walk, for example. That is also something what people learn only if they lose their ability to stand up. Also, there are many aspects of mobility that play a big role and are associated with the sense of self. Interestingly, not with everyone. So many experience the problem of mobility only when it occurs. And also one signal we should send from a clinical point of view to all of the people is start as young as possible with your training of mobility. Then you will have resources when it comes to issues with mobility when you get older.
Thank you for that. John, you were nodding your head there about the whole training side of things. That seemed to resonate with you.
It did very much, because like with COPD, as I said earlier, it's a slippery slope. If someone needs pulmonary rehabilitation, for example, or an exercise program is recommended by their clinician, the sooner you do it, the sooner you get in the habit of doing that. Because once you become so deconditioned that you perhaps can't stand up, or perhaps just say, well, I can't do that. I just can't do that. Then you're not going to get there. You walk before you crawl, before you walk before you run. We've all heard that. You need to start somewhere. And if you can only walk halfway to the mailbox and back, then walk halfway to the mailbox and back. And maybe after a week, you can go 3/4 of the way, et cetera, et cetera. You have to start somewhere, because it doesn't benefit anyone, especially you, to just sit and do nothing. Mobility is key to better outcomes. And we're going to get into this later, I'm sure, but I think it needs to be an endpoint in research.
Thank you. So we've kind of touched upon, well, first of all, we do seem to be in agreement as a group about the importance of it. But we've touched upon some of maybe the difficulties in terms of actually realizing that importance when we have patients and clinicians together. So on that, we might come back to discuss it, but we might play the second video first, and then kind of go into that in a little bit more detail.
My walking changes, you know, some days are much better and some days are not as well, not as good as the others. For example, what I said before, if I'm not walking, if I'm not doing my walking exercises, you know, like it will make my walking worse. And those changes are really bad, not only physically, I think they're really bad emotionally. And I think that this is something that we need to address, the emotional part of the movement disorder. And I think that a positive attitude, you know, it sounds cliche probably, but a positive attitude helps with dealing with it. It took me, when I was diagnosed, it took me several weeks of really deep depression until I think I fully comprehended what I'm facing. But I said to myself, okay, this is what's going on. I have two choices. I can really get into a hole and stay there until everything passes, which it won't. Or I do something with myself about it. And I started to looking for things to do to improve my quality of life.
Years ago, I made the cover of the COPD Foundation magazine, And it was a picture of me zip lining. And how did I get there? I got there because I wanted to do that. And as we're struggling up the hill to get to the first platform, to get onto the zip line, my 86-year-old mother-in-law said, "Are you doing okay, John?" I thought, I'm fine, Bev. We're going to get through this together. And we had the best time. I zip-lined and I felt great because I was mobile. I was doing what I wanted to do. And it took more planning. It took me more time to do it, but I can still do it.
I can't walk straight. That's one point. And my calves, after maybe 500 yards or so, they start to ache. They're trying to get me back online. And the Parkinson's saying, "No, you're not going." And my calves say, "Yes, you are." Then I get pain in my lower back because of the way I'm walking. My body says, "Walk straight." The Parkinson's says, "No, you don't walk straight. You get Parkinson's, you walk a different way." My friend has got Sky TV. So we'll go and watch the Bundesliga, the Premier League football. It takes me half an hour to get there. Used to take me half an hour to get there. And Saturday, I had to sit down on a bench and have a rest. So I sat down for 5 minutes and I went again. And that's something that never happened before. I don't know, maybe just I had a bad day or it's getting worse, or but that's I had to. And beforehand, it was straight through, no problem.
Video actually probably carried on quite nicely from where we were discussing just before we went to it. So you know, we heard kind of there about the importance of walking in terms of being more than just a physical act. You know, Tova, you mentioned that there was initially a sense of deep depression. John, you know, you mentioned about having to really dig in deep and work against it and to make that decision. And we heard from Tom about needing to plan much more in advance and to rest. So there was a sense, if I'm correct, that there was an awful lot of an emotional side, or I suppose a planning side that might be quite tiring, actually, if you're always thinking about it. Do we, pulling on from, I suppose, what we were talking about before, that some of this can get lost when we speak to our healthcare professionals, how do we think we can make that communication between patients and healthcare professionals a little bit stronger so that this complexity is really well understood? I might actually open this time with Nikki, if you don't mind.
Yeah, that's not quite easy to answer because everybody is so different and walking is so multifactorial. So it really depends on the person who you're speaking to, what their specific problem or their major specific problem is. My patients are very old people, about the age of 80 plus. And for them, it's really difficult to tell what is about. Even quite a few reduce the locus of control and mobility because they say, now I'm old enough, I don't have to do that stuff, my family members can do. And so they lose them parts of their mobility. And at first, it's not quite sure what gets lost first. Is it the confidence which gets lost, or is it? Can they really say specifically it's balanced or strength? You have to ask in many ways, and people shouldn't be shy to say what their problems in their in life are, so the physicians can get an idea of what might be the problem with the mobility. Okay, thank you. And Tove, then from your perspective, because you were obviously talking there within the video, how do you feel when you begin to speak to a healthcare professional about this? Is there a shyness or an uncertainty, or from your perspective, how does it feel?
I think it's rather complex. Nikki said a few important things. My feeling recently is that you get to your physician and he reads the questions from a sheet that has a list of questions to measure more or less the progression or what are you doing. It seems a little bit detached to me. And I think that something is missing in the patient-doctor relationship in this case, I think there should be some kind of, it seems a bit impersonal when you come to your physician and he reads a list of questions from a questionnaire in order to examine it. I would credit my physician that he emphasizes every time that we meet, he emphasizes the fact that I need to exercise or to be physically active at least 5 hours a week, which is nice, but as Nikki said, most of our patients are in their 80s. I'm not getting very far away from them, but at a certain point you say to yourself, you know what, you want to rest sometimes as well, and you want some other people to do some stuff for you, but that's not the answer actually. But I think that there is some link missing between the doctor-patient relationship in this case. And I don't know how it goes in other countries. I had a mixed experience in this, so I know that it exists, but as Nikki said before, I think there are two sides to the coin, and it's complex. It's really.
Yeah, absolutely. And Werner, you actually mentioned complexity at the very start as well. I suppose coming from a different country, then what are your experiences? Do you feel similar to Tove, or do you have something different?
But I feel very similar to Tove and to Nikki. It is very complicated to tell a physician how good you walk, how good your movement is, stuff of this nature. What Tove said, they've got a list of questions and they try to assess you and they assess you on the day you're there. And this is just a snapshot. It doesn't show the progression of the illness. It doesn't show the progression of the problems. This is something I actually would like to see in future, a measurement of how good the movement is, which is not only a subjective description, but an objective measurement.
Yeah. Absolutely. And we probably will touch on that a little bit more after our third video. I might just move on to Walter, and then I'll come back to you, Tove, there, so you have your hand up. Walter, obviously, we've heard, as Tove has said, there's two sides to the coin, and it is a very complex topic. So how do you think we could maybe narrow that perceived disconnect? Because obviously, clinicians only have a short amount of time, but we know how important this area is for both sides. What do you think in your experience might be done?
I think this is a huge topic, and so I'm maybe coming from a different angle. I think we are now moving into a digital area of medicine, and this will change our interaction between patients and doctors dramatically. And the NHS review, the topic review reports that the main aim of the digital medicine should be that doctors have more time for their patients. This is an interesting aspect. We often think that everything what is digitalized is more unpersonal, but this may not be the case. So if we really manage to save time, then it may be really to the benefit of the patients and maybe also for us medical professionals, because it's also not fine not to have time. This has nothing to do with mobility at the first view, but still I would say, so we are here because Mobilise exists. This is a very, very interesting development where we go also in the home environment, assess there these important aspects of, for example, mobility, but you can go beyond, and you assess the information that people really need to understand how a disease influences their daily life, that you have to assess in a home environment and nowhere else, and not in a doctor's practice or in a hospital. I think this is a super interesting and important development. So this is my view, and I appreciate we have a problem with this patient-doctor interaction, but still I'm optimistic that it will improve.
Yeah, great. John, you're nodding again. What are your thoughts?
I guess I nod a lot. It's actually 2 or 3, maybe 4 different topics we're all talking about at once, and I'm not sure where to start, and I know my time is limited. With COPD, at least in the United States, so few patients have access to pulmonary rehabilitation. And sadly, many clinicians aren't really aware of how much that can help. And I'm talking about primary care physicians, obviously pulmonologists and lung doctors do. Just real quick, an interesting story. Ted Koppel, a very well-known journalist here in the US, and his wife, Grace Ann Dorney-Koppel, who has COPD, have a foundation, and they go into poor areas. And they walked into a doctor's office one day, Dr. Dan Doyle in West Virginia, said, "We want you to head up a clinic." He said, "But I'm a family doctor. I don't even believe in pulmonary rehabilitation that much. Why are you here?" I'm making it a very short story. Now he runs their clinics down there, and he's a firm believer in it. And he says, "I was a naysayer, and now I'm all in." But now quickly back to the relationship between the patient and the doctor. I work with a lot of patients, and I have the opportunity to speak to a lot of physicians. The patient says, "Well, my doctor doesn't explain anything to me." I say to them, "Did you ask them?" The doctor says to me, "Well, my patients don't listen to what I tell them." And that's where the disconnect is. So I tend to talk in buzzwords. Now, I've done whole presentations on this. It's called being partners in care. Patients and physicians need to be partners in care. So when I tell the patients that are frustrated with their doctor not listening to them, is tell your doctor, say, "Hey, doc, I know that what I do has a lot to do with my quality of life and what you're trying to help me with. So why don't we be partners in care? What can I do and how can you help me?" And I guarantee that doctor's jaw will drop open and he'll spend that extra 5 minutes with you because you opened yourself up and you're willing to be a partner with him and listen to what he wants you to do. It makes all the sense in the world. Physicians and doctors need to be physicians and patients need to be partners.
Thanks, John. And I think, again, as you said, you've touched on a couple of different bits there, similar to what Walter and Nikki were saying about, just understanding, I suppose, each sides and not being afraid to come forward, but also spend that little bit more time on things. Tova, do you have something else to add there?
Just a little something. What I mean actually is for the physician to be able to see the patient behind the questions. Not to see the questionnaire, but to see the patient. I don't think that it's very important to ask the patient how constipated he is, but to feel the patient. That's what I mean.
So just a more personal sense then, by the sounds of it, yeah.
Not necessarily personal, but to see the whole person behind the question.
Okay.
He doesn't have to go out to have coffee with me.
Yeah, fair enough. Back to that sense of identity and the independence, isn't it?
Absolutely.
Clemens, I see you've joined us. I'm not sure at what point you did join us, but we were just kind of, as you probably will have seen, that talking about how we can, I suppose, bridge the gap a little bit more between patients and clinicians. I don't know if you have any thoughts from what you've heard at the moment on that.
Yeah, on a conference it might be a bit noisy. First, for now, I think I would still like to listen a little. I think this is very interesting. If there's something relevant, I'll raise my hand. Thanks, Alice.
No problem. I wanted to give you the choice there. So what we might do, you've actually started to touch on some of the things that we'll be discussing on after our final video. So what we'll do first is just play that, and then we can get into our kind of final bits of discussion for the last 20 minutes of the webinar, if that's okay. So our last video is coming up now.
First of all, every time I see him, he tests my walking, but I'm discussing with him also the fact that sometimes I have lows in my walking, that I'm not walking well. Usually at the times that I'm seeing him, I walk perfect. It's always like that. But there are times that my walking is far from being perfect. And I'm telling him what happens at certain times when my walking is not as I would like it to be. And actually, he's very strict about exercising. He always says to me, you have to exercise at least 5 hours a week, 2.5 hours aerobic and 2.5 anaerobic.
The clinic I go to, they know everything about me that can be known about my condition. You get the treatment, everything you get. Puzzles to do, how do you walk? Stand in one leg, stand in the other leg. See how far you can walk in 6 minutes, things like that. I used to go to a neurologist every 6 months, and he's in there, how are you doing? I say, I'm okay. Yeah. I say, I'll walk a bit staggery. Okay, yeah, we'll just keep your medication. Okay, there you go. Go and see the girls. That's it. I'll see me longer waiting in the waiting room than actually being with the doctor or the neurologist. They might be under a lot of pressure, and I'm just another number. I'm not falling down anymore since they changed my medication. But as long as you can get from A to B, no matter what it takes, I feel as if they're not really interested. They don't really care if it takes me half an hour or 3/4 of an hour. As long as I can get from A to B, they're quite happy. You've actually got to have the condition to know what it's like.
Actually, neither my primary care provider or my pulmonologist asks me when I do see them how much I walk each day and how active I am, and am I able to navigate stairs, get to the mailbox, go to the grocery store. It's simply not brought up. And actually, it probably should be about mobility, walking. How active are you? How much television do you watch each day? See, that is a telling question. If someone is really, really good at watching daytime television, that means they're sitting on the couch with a hose in their nose. They're not walking, they're not being active, they're not taking care of themselves.
So again, there, I suppose we've kind of followed up quite nicely on some of the things that we were speaking about before we saw that video. So at the last discussion point, I suppose, Walter, you brought up the whole topic of, digitization of outcome measures and the types of questions and things that we're starting to look at. And you can see there that, I think it was Tova said that, you know, sometimes she walks perfectly when she's there, but then at home it might be different. So there is a kind of a sense that actually we may need to look at things slightly differently, or again, coming back to that idea that the questions that are asked in the clinic may not be always very reflective of real life. Within Mobilise-D, we're obviously looking to start measuring walking in the real world. So bearing in mind, I suppose, everything that we have talked about at the moment, and some of the problems that we've highlighted, how do you think that this research that we're doing in Mobilise-D might help some of the challenges that we've spoken about today? I might open up with Tova first, if that's okay with you.
I'm not sure about your question, but as for the research, I think I mentioned it to you before. It's great. It's great that it gives a lot of information to the clinician, but I would really be happy to see the information it gives to the patient, or what the patient can take away from this or learn from this.
Okay, so it's more information for everybody, not just from a clinical side.
Absolutely.
Yeah.
To be available to the public.
Perfect. Okay. Nikki, what are your thoughts on it? And, you know, I suppose particularly in kind of thinking of some of those challenges that we've spoken about, how might the work that we're doing in Mobilise-D help that?
Yeah, I'm really looking forward to visualize the mobility for the doctors and for the patients as well, because our time in speaking with our patients is often very, very short. And you just see them coming in and maybe sitting down and standing up from a chair and going out of the room. But you don't see the problems in between the whole day, and the amount of mobility in daytime. And I'm really looking forward to visualize it to people even at an earlier time point when things are still going, so they can have a follow-up and see when things get worse, or even the beginning of it, so we can act earlier to encourage people to stay mobile.
Okay, so that idea of seeing what's happening a little bit quicker, but also the information being presented in a different way than maybe you currently are able to collect it.
Yeah, and maybe also encourage people to keep on exercising and moving when they see in a progress of exercising and therapy that things might get better by doing so.
Okay, thank you. Walter, you mentioned the last time about the whole digitization, which is obviously linking in with what we're doing with Mobilise-D. Nikki's obviously spoken there about sort of similar to what Tom said in the video, that sometimes in a clinic, we only have the opportunity to see someone stand up, sit down and walk a little bit. So from your perspective, then, how will this work of Mobilise-D, I suppose, narrow that gap in terms, or improve, widen our visions even in terms of what we can understand?
Maybe it will bring us back to the roots, because I think I agree with Tova. We should not too much focus on medical problems and aspects when we talk about mobility. This is the way we have been practicing in most societies, that we observed the person and felt a little bit of what is going on with this person, and then went into the details of the symptoms, etc., and also brought them to a hospital if needed. But we had now, I would say, 50 to 80 years of medicine where we did it differently. So we started to investigate indeed in a professional environment, and this is something which is not natural, and it is also not in our nature, I think. And so this makes me really optimistic when we are talking about digitalization in the home environment to assess people, maybe also to treat people. Then this is something where we go back where we felt always much better and much more natural than we did during the last decade. So this is also something what I have to say as a medical doctor, and also a little bit criticizing our profession, to be honest. But feeling very comfortable with the new development also where Mobilise is part of it.
Thank you. Before going on to John and Werner, Tove, I might go back to you if that's okay. Just to see kind of, you know, how that feels from your perspective now, that whole idea of seeing people at home or in the real environment, and how that links back to what you were saying earlier about, you know, seeing the whole person.
I will feel much more comfortable with it. I will probably have the feeling that the doctor gets me. It's not like asking me the question and saying, well, you need to do A, B, C, and D, and that's it. I had an encounter not long ago with a physician that I complained about something, and he said, well, take this medicine, half a pill. And I looked at him and I said to him, I've been your patient for about 3 years already, and this is the first time you mentioned this to me. And he said it in a tone that was so obvious. You know, what's the problem? It was, I said, it's a problem because it's the first time I'm hearing of it. So this is an example that.
Okay, thank you. Clemens, you've got your hand up.
Yes, thank you. I would like to give maybe a few examples where we are almost there and should be using this. So for instance, if let's say someone is a COPD patient or a patient with heart failure, and they're used to say, let's maybe take 4,500 steps or something, and they're relatively stable. And let's say if their mobility decreases, let's say to something around 3,000 to 3,500, it's definitely a point where they should seek the advice, let's say from a COPD pneumologist, to see if something's wrong and maybe the medication has to be adjusted. Another example would be if you have an MS patient and they go from relapsing to chronic progressive, and you see that their walking distance, this is something we can measure with our device, gets less and less and less, is less, for instance, than 250 meters. It might actually mean that you have to switch from one therapy to a very different agent. If we would see, for instance, in Parkinson's patient that the number of freezing phenomena and other, let's say, problems with mobility increase, it's time to think about maybe to adapt the medication and so forth. I think there's so rich information in mobility, and very often it's not specific, but it's very sensitive. So it tells us that something is changing. For John, for instance, it could mean that we could identify people that should qualify for a pulmonary rehabilitation program. Maybe they have had an exacerbation, and then the discussion is this maybe inpatient, outpatient, what is it? And based on these findings, we could definitely say this is a stratification help to see this is something that someone who definitely should be part of such a rehabilitation program and then would qualify it. So I think we don't have to wait for the next 3 or 4 years. There are so many already existing use cases, and we need to bring this to the, let's say, patient, but also, let's say, to the healthcare professionals to make use of that.
Okay, thank you. John, your thoughts on this, because obviously, you know, you've spoken quite strongly about the importance of physical activity and it links to you. How do you feel about this, I suppose, becoming part of your outcome measures or how you would manage your condition?
Happy to speak on that. And again, and first I want to compliment Clemens because he addressed the possible alternatives for all 3 conditions, MS, Parkinson's, and COPD. So he's just a virtual font of information. Good for you. But again, we have 2 questions. We have, how can this benefit research? And what Tove had brought up, which is very interesting, are we treating the person or the patient? And for years, when I lived near Mayo Clinic in Rochester, and Mayo Clinic is world renowned, when I would see my pulmonologist, he'd say, he'd walk in the room, how are you today? And I start talking about my breathing. He said, no. How are you? Let's talk about you. How are you feeling? What are you doing in your life? And he wanted to know the person, not the patient. And he devoted a full 5 minutes to that. And at this point, we still collaborate and do research together. I, as a patient advisor, he's a wonderful doctor, Roberto Benzo, wonderful man, teaches mindful awareness. Anyway, enough of a plug for him. But that's where I learned that a good physician treats the person, not the patient. But I believe the question was really about how does the research of mobility help in the long run? Whether it's right or whether it's wrong, empirical information and research is needed. So what I envision is Mobilise-D coming to is you need to get researchers to incorporate that as an endpoint and put that into their research, whether it's MS, COPD, Parkinson's, whatever, and do that. And then hopefully, dreaming on a cloud, that mobility might become an endpoint that becomes a core outcome in all research. And that's the purpose in my mind of what Mobilise-D is trying to do. And the only way you can do that is to get researchers to incorporate mobility into their research as, maybe not the primary, the overarching goal, but as a secondary measure. And that's where you start. And I know I sounded like a researcher, but I do enough of that as a patient. But anyway, I really think that's what needs to happen. And I would be very interested in either the audience perception of that or the doctors on the panel.
Definitely. Before I do open that up, I might just hear from Werner, if that's okay. So from your perspective, Werner, I suppose hearing what Clemens and then just John have said most recently, what do you think about that whole idea of incorporating mobility as an outcome measure and using that to understand what's happening at home in real life?
Well, actually, mobility for me is sort of a personal biomarker. If I'm mobile on a day, my coordination is better, my thinking is better, my talking is better. And so I actually can extrapolate from the way I move, how good I really feel that very day. And so it's what John says, it's a major thing to discuss with the physicians. And they need to understand that it's one of the absolute must understand things in our illnesses. And from this point, we also need to make sure that there's only the status when you're with a physician, not only the status over a day, but the deterioration or the changing over a certain amount of time, which gives an indication on your illness and what to do with it. So it's one of my major priorities that I see.
Thank you. I think we probably are all on the same page with that. What I might do is just with the last couple of minutes, just open it out to the floor to see if there is any specific questions or comments on this or any follow-up points that any of our panelists have spoken about today that someone would like to speak about. Or any further thoughts or comments from any of our panelists based on what we've just said for the last couple of minutes.
The only comment I would have is we need to do something. We can't, talking about it is one thing, acting is another. So, but that's up to the researchers. But we can talk and talk until the cows come home, but talking doesn't get the job done. Yeah.
Well, sorry, go on, Werner.
But I also see this as a part of being a patient on this board to bridge the gap between the patients and the researchers.
Thank you. Yes, and I think, as Clemens said, if there's enough kind of information out there that we can already start, and then hopefully the work of Mobilise will push this on further in terms of helping us to understand what's going on at home and how powerful that is to people, and then using that information to hopefully bridge that gap. But in the meantime, hopefully the work that we're doing collectively, it does go away to take a couple of small steps in that right direction. I'm just conscious of time. We've almost timed this to perfection. So if there's no questions from anyone else, I would just like to take a moment before I hand over to Mara to thank everyone for attending. The recording of this will be available on YouTube for sharing, but I'd also like to thank each and every one of our panelists who have very kindly given us their time, their experience, and their opinions here today. I think it's great to get together and to even use ourselves in terms of starting to bridge that gap. So thank you all very much. I do really appreciate it.